Our peer group chose acute ankle pain with distortion, grade 1 ATFL ligament sprain, and ankle inversion mobility deficit. And our group members were Mickey, Caitlin, Aaron, and Straw.
According to the CPG for lateral ankle ligament sprains, the anterior jaw test and the anterolateral talar palpation should be used to rule in an acute ATFL sprain. Before anterior jaw testing, I asked the patient for their consent and then proceeded by having them lie supine with their affected leg bent. A towel roll is placed under the foot in order to maintain the ankle in about 10 to 15 degrees of plantar flexion, as shown by physio tutors. My mobilizing hand is placed at the distal third of the tibia and fibula, and the stabilizing hand at the other stabilizes the foot. I then applied an anterior to posterior translation in order to produce a relative anterior glide of the talus within the mortise. The test has a strong clinical value for acute sprains, but low for chronic. A positive anterior jaw test would reveal increased anterior translation of the talus compared to the unaffected leg, and a dimple may be visible at the anterolateral aspect of the talus bone. In order to rule in an ATFL sprain, a pinpoint palpation of the ligament can be performed. By coming anterior and inferior of the lateral malleolus and applying pressure, the PT can assess the ATFL individually to confirm the affected ligament after the anterior jaw. In this case, the patient should feel pain in the area with pressure. Since in the case the basketball player has experienced a grade 1 sprain, they should feel pain with no excessive motion during the ATFL stress test. For the ligament test, the patient was positioned in supine while I stood on the medial side of the patient's foot. My mobilizing hand was placed on the patient's talus and my finger located on the lateral aspect of the bone. The stabilizing hand is located on the distal tibia and fibula. Once I had my hands in position, I brought the ankle to mid-range plantar flexion and adducted the talus. In order to allow for anterior glide of the talus, I also pulled the mortise from the mortise to the greater stress the glide. As I do this test, I'm feeling for excess motion and compare it to the opposite side and pain provocation. For this case specifically, the motion should be comparable to the other side, but there should be pain provocation.
Hi, my name's Caitlin. I'm going to be your student physical therapist today. How are you?
I'm doing good.
Okay. So basically what we're going to be doing for our treatment today is we're just going to assess some of the glide in your ankle. So we think that you have a lateral ankle sprain. So we're going to see if we're just going to move your ankle in a few different ways, and we're going to see if that makes your symptoms better, worse, or stays the same.
Okay.
Does that sound okay with you?
It does.
The posterior glide of the distal fibula was performed in order to treat a suspected anterior-inferior positional fault of the distal fibula, often associated with an inversion ankle sprain. So the goal here is to appraise the movement quality of the distal fibula on the tibia and identify a hypothesized anterior-inferior positional fault that often restricts motion following a plantar flexion inversion injury. So here you can see I stabilize the distal tibia and then apply a posterior directed force to the lateral malleolus by using the thenar eminence on the anterior side of the fibula, stressing it posteriorly to apply the glide. While I'm performing this, I'm also monitoring for symptoms alleviation with the movement, while also assessing the end feel to determine if the motion is restricted and if she's hypomobile. A restricted posterior superior motion during the assessment suggests an anterior inferior positional fault contributing to an inversion and dorsiflexion restriction. This assessment confirms the mobility deficit before we apply the mobilization with movement intervention.
All right, hi Caitlin. So after doing the movement with this bone right here called your fibula, after doing a little bit of a posteriorly directed movement with my own force, we saw that you had improvements in your symptoms that you came in with today. So we're going to do what's called a mobilization with movement. So I'm just going to have you set up in a different position, and I'm going to be applying that same force and then having you work in a certain movement, and I'm going to have you do some reps of that today, okay?
Okay.
So I'll explain what you're going to do. I'm just going to move the camera here. So I'm going to have you move into what's called inversion and plantar flexion. So you're going to come in and out of that as I'm applying that force with my hand.
Okay.
Does that make sense?
Yep.
Okay. For our manipulative therapy technique, we decided to do immobilization with movement, focusing on the distal tibiofibular joint. Since we had an inversion ankle sprain of the ATFL grade 1 on the lateral side. With this technique, we are addressing the positional fault of the distal fibula, as we hypothesized to be an anterior subluxation, which occurs in the inversion plantar flexion ankle injuries, as we're seeing here with our own case. And this is causing pain with inversion plantar flexion and limited mobility into dorsiflexion. This technique applies the sustained glide to correct the positional fault and should result in the movement being painless or significantly reducing the patient's concordant symptoms. And really focusing on that pill principle, it should be pain-free, have immediate improvement, and be a long-lasting effect. So for this, the patient was supine with the patient's tibia stabilized by my hand, and the heel of the plint's edge is where they were located. They really should have the ankle hanging off. The therapist mobilizing hands, thenar eminence, contacted the anterior side of the distal fibula. From this position, I first applied a posterior directed force, and then I dropped my elbow a little bit to really get that cranial glide as well as the posterior translation. So for this, it's really going to correct the suspected anterior-inferior positional fault. While maintaining the glide, the patient was asked to invert and plantar flex their ankle. The motion should be painless or at least reduce their concordant symptoms significantly. I applied overpressure at the end of the patient's active range of motion, and I still sustained that glide throughout the whole entire movement from start to finish. I didn't let up until the 8 reps were over. I had them do 3 sets of 8, and they do like a 2-second hold at the end range and then come out of it while I still sustained that glide. And then I would have them rest for a minute in between each set of 8. This mobilization movement technique specifically treats the positional fault of the lateral malleolus that is hypothesized to occur with inversion and plantar flexion injuries like the ATFL case that we're working with. And restoring this posterior superior glide helps normalize fibular motion during dorsiflexion, which reduces abnormal talar glide and relieves concordant pain. A retest for this would be to measure ankle range of motion to ankle dorsiflexion and note instant improvements in range and pain provocation. A certain test we could use is the weight-bearing lunge and having them lunge towards the wall. And we can get a good measurement that way of their increased dorsiflexion. And then we would want to reinforce this with corrective taping for the subsequent 48 hours. And then we would repeat this mobilization movement at follow-up visit. And keep following that pill principle as well.
The taping technique that was most beneficial for this case is the distal fibula sustained posterior glide taping. The patient was previously screened for all contraindications and allergies. The patient was also educated on leaving the tape on for 48 hours, but they were instructed to remove the tape if they feel any discomfort, such as redness, burning, or itchiness, and they should notify us at their next appointment. The taping technique is used to reinforce the correction of a suspected anterior-inferior positional fault of the distal fibula. It was performed immediately after the successful mobilization with movement that restored mobility and reduced the patient's concordant sign. The goal of this taping is to provide compressive support and maintain the corrected posterior-superior position of the distal fibula, which is often displaced in an anterior-inferior direction following an inversion injury, such as the one in our case. To start off, I applied a protective coverall tape to the area, and you'd want to avoid coverage over the talocrural joint and the Achilles tendon insertion point, and be careful to avoid wrinkles in the tape that could cause issues like Achilles tendonitis. I also extended the coverall tape from just above the lateral malleolus to above the medial malleolus. I avoided circumferential placement, and then I anchored the leukotape just above the lateral malleolus and pulled it over to achieve tension over the fibula. Then I applied a posterior glide with my thumb onto the fibula while placing the leukotape to reinforce the positional correction. This will allow for increased support of the distal fibula, which can help restore normal fibular motion during dorsiflexion, thereby reducing abnormal talar glide and relieving concordant pain associated with the positional fault.
Hi, okay, so now that we're done, we finished with all of our evaluations and everything. Our plan going forward is we probably want to avoid any basketball activities, so any like cutting, jumping, anything like that. completely for the next like 7 to 10 days.
Okay.
We do want you to walk, but do like a weight bearing as tolerated, so however you feel, just to kind of get that motion back and keep it going.
Okay.
We did notice there was quite a bit of swelling, so I do recommend doing like what they call it the RICE method. So it's just rest, ice, compression, elevation. You can leave the ice on. Don't leave it on for more than probably like 20 minutes at a time. Take the same amount of break. If you want, you can go again. However you feel. If you feel like you need some, but that should help bring down the swelling, the elevation above heart level. And then so for some exercises that you can do at home, because we do want to still keep that ankle moving, is we can do some ankle circles. So you can lay back if you want, or you can sit with your foot hanging off the table, and we can just do some ankle circles. We can start nice and small. You can get bigger as you go. We probably want to do about like 30 of these. And then you can take a break, you can switch directions, but you probably want to do this 3 times, like 3 rounds of this, probably 5 times a week, if we can. And then we can do, once we're done with those ones, so those look nice and good. We can also do some balance stuff, so we can just stand, try to have equal weight bearing on both legs. If you feel comfortable with that, does that feel easy for you?
Yeah, that feels okay.
Yeah, if that feels super easy, we can always bring up our good leg and balance on our non-dominant or our uninjured leg. Good, and then when we do these, just try to make sure that we're standing nice and tall and that everything is in a line. So we don't want that knee to cave in or out, just to get some balance back in there, and then you can relax. But we would hold that for like 30 seconds at home, probably 3 times. And then same thing, probably 5 times a week. Whenever you do the circles, you can do these.
Okay.
Does that sound okay?
That sounds great.
Great. Do you have any other questions?
Nope.
Okay.
According to the CPG for lateral ankle sprains, those that have this acutely can highly benefit from prophylactic bracing to be able to effectively bear weight on the affected limb. This is all dependent on the phase of tissue healing and severity of injury, as bracing can provide external support. Bracing and taping can be very useful to reduce activity limitation and lessen participation due to their lateral ankle sprain. Based on our patient's acute grade 1 ATFL sprain, most likely their symptoms can be mitigated with the RICE principle as introduced by Caitlin, or the minimal taping technique that Aaron showed today. If the patient was at very high risk of re-injury during gameplay, then more restrictive taping or bracing can be utilized. I just wanted to address this because I feel that someone that's had an acute ankle sprain may just quickly jump to bracing, and it's just important to try and utilize those other methods first. But if someone needs a brace, that definitely can be used, especially because the CPG highly recommends it, especially for grade 2 and up for ATFL sprains. We also want to address that we would also want to look at the peroneal strength and do some isometric exercises with that as well. Most likely doing like a 10-second hold about 8 to 10 times, but having them do that for 3 sets of about 10, really focusing on getting the isometric peroneal strength back, strengthening those everters, and overall just helping stabilize the ankle as well.